This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
Hello, everyone, and welcome to Caregiver Chronicles. My name is Sarah, and today I have Joan Dipaola with me. Joan has more than 20 years experience in nursing and dementia care. She's a champion of person-centered care, and her work has completely eliminated negative language surrounding dementia-related conditions in Care One facilities. She also, this year in 2024, won a McKnight Pinnacle Award, the Thought Leader Award, and I'm so excited to have her here. Welcome, Joan.
Thank you very much. I welcome the opportunity to speak about dementia, which is a passion of mine as well.
Thank you. And congratulations again on the McKnight Pinnacle.
Thank you to Care One. Thank you to McKnight for the opportunity to spread the word about how we as leaders can change the negative impact that's associated with the disease of dementia. So I look forward to talking to you today about that.
Thank you. But first, would you like to further introduce yourself to my audience?
Sure. My name is Joan Dipaola. As Sarah said, I have 44 years experience as a registered nurse working in acute care setting, a medical teaching environment. And I branched out and started a medical daycare for seniors with Alzheimer's and dementia, ran that successfully for 15 years. I started a home care agency, and I was the director of the program as well as the nurse educator, and educated people going into other people's homes to care for somebody with dementia, so they became knowledgeable and skilled. And I also then came on to Care One to be the nurse educator for Care One in its all dementia first building for Care One, which is all dementia care, 126 residents. So I train the staff and I train families on the proper approach so that people can live successfully with the disease.
Thank you so much. And that's incredibly important work. People don't realize how much training is involved and needs to be involved, and how much education needs to be continued for healthcare workers who care for dementia patients. And this is even, you know, at the bottom, the nurses aides who, you know, often get looked at as the bottom, but are really doing the brunt of the work. They really need good training to work in dementia care. There's always extra training for that. And that's super important work. I was always grateful for those opportunities, for those trainings, because they always helped me understand the people I was taking care of better and what I could do better. So I appreciate that. So I guess kind of getting more into, you know, your work. And I know healthcare has a really long history of using language and words and terms that we don't realize are hurtful to the people that we're taking care of. Other examples of this would be like the R word to describe people, you know, with intellectual disabilities and stuff like that. There's better terms. When did you realize that there were that the words we were using with dementia, and that it was negative, like there was negative terminology with dementia, and it was impacting the people?
I learned it very early on in my career when we were not trained. As I said, I'm a nurse for 44 years. And when I went to school to become a nurse, the emphasis was not on dementia. People were called pleasantly confused, and we didn't have the education and support. But I became very passionate about it when I saw that if we took the time, an unhurried approach, we used positive words, the outcomes became positive. So very early on in my career, I started doing a lot of research and studying. I studied under Teepa Snow, the world-renowned dementia care expert in the field. And she puts a lot of emphasis on our language. The disease has a negative stigma to begin with. The society looks at dementia as people that no longer have abilities to function. And so our words really matter. And we need to change that negative stigma and put the emphasis back on who the person is. And when we use terms that are infantile, for example, such as diapers or bibs, we're treating these people as children or toddlers and not adults. So our emphasis is on the positive words for positive outcomes. Because of the negative stigma associated with the disease, there's a lack of outreach for the proper care with their physicians, pharmaceutical interventions, and the risks that happen when they're not in the right products, they're not in the right environment, leads to higher costs for the medical care that they need or the lack of medical care that they're getting. So our words really matter. But when we speak about language, Sarah, we're not only talking about our words, we're talking about nonverbal communication as well. We tend to, when we get frustrated and we have a normal, healthy brain, what do? We try to roll our eyes sometimes. We might huff and blow. We might lean into a resident when we're speaking, which can be misconstrued as being very confrontational with the resident. And so not only what I'm training the staff is to be more cognizant of our verbal language, but our nonverbal language is critical to the success of taking care of somebody. And also touch, how we touch a resident and not asking for permission can lead to untoward behavior. So language encompasses so many different aspects of dementia care. Our hurried approach when we're speaking very fast to a resident, we need to slow down because there's a processing delay. So language is critical to the success of our positive outcomes.
Yeah. No, I 1,000% agree with you. I don't think that there was ever a situation that I had come across in my 17 years of working as a nurse's aide. And even now in the facility where I'm a receptionist, if a resident who has dementia comes in, and is confused, there is never a time where, if I'm agitated and you're approaching them agitated and you're already upset because of what happened in the last room, they know, it's your body language again, you're just whatever's around you, so like take that deep breath. But also there's never a time where the words that you use, and if you don't use your words carefully, where it can't be offensive. I have had to de-escalate a lot of situations in dementia facilities. And sometimes it's as simple as just the approach. You just walk out of that room and a half hour later, you walk back in with a different approach.
Yeah, I try staff to take that 5-minute deep breath, get your composure. They're speaking in nonsensical words. Language is the first to go with dementia. We lose language on the left side of our brain first. So sometimes they're trying to communicate something with words to us that makes no sense. But if we react negatively or laugh inappropriately, the response could be confrontational back to us. So our words really matter. And because of the processing delay, we have to have that calm, unhurried approach to maintain effective communication with them as well. So we also train the families, and we have to put the emphasis back on who this person is. We have to look at unmet needs. What are they trying to communicate to us? So we're interpreters as well to that nonsensical language that they're speaking to us. And we have to assess for the unmet needs. Are they hungry? Are they thirsty? What was their night like last night? Are they sleep deprived? Do they have pain? Is the environment overstimulating, understimulating? Is that the trigger? So our words and our nonverbal communication, it creates the positive outcomes we're looking for when we lay the foundation for our care here at our facility at Care One. That's our first course that we teach, is the paradigm shift using positive words. Don't label the resident, learn their life story, get to know who they are, so that when we lay that foundation, it promotes the effective communication that's needed to lay the groundwork on how to build upon that.
Yeah. And I agree with that. And I think that I really like the learn the life story approach. I think that that's important too, because there's so many, I think we've all heard like the milkman story before of, the resident who was a milkman who woke up at 2 o'clock every morning and all they did was give him bowling pins to put out by doors, and that just changed the resident. He was better after that because he was a milk, and that's what he wanted to do, was deliver milk or whatever it is in the life story. I think it's important to know the social history of the people that you care for. Even if you're an in-home caregiver, if someone was abused, you definitely don't want to put your hand on them without making sure that you're letting them know beforehand. Like, even if it's just a hand over hand thing to let them know that you're listening, you don't want to do that without their consent if there's someone who is abused. These
Right.
are so important and so simple things that a lot of times healthcare staff just don't think about.
Yeah, as you said, the life story, we obtain that on pre-admission so that we're prepared for somebody moving into our community. And occupation is the icebreaker for that opens up the communication between us and the person moving into our facility, because people love to talk about how they earn money, what their interests are, and that promotes engagement in therapeutic activities. When we know what their life story was, their occupation, what their interests and their likes and dislikes are ahead of time, then it creates success on move-in day. It's familiar, they trust us, and the activity department can start planning for this new person coming in to meet their needs and to almost give them a sense of comfort and trust with the staff, that they know who I am and they're not focusing on the disease. Because in the early stages of dementia, when they generally move into our community, they lack safety awareness, they have exhibit poor judgment, but they need more support, either with written notes, calendars, and tools to help enhance that, pull out that long-term memory. They come in and they feel stigmatized already because of the disease. And our mission here is always to promote best ability to function, maintain independence, but that social connection is critical, because as the population ages, they don't have that peer relationship, that peer connection that they've had before. So our facility gives them an opportunity to connect with people that are experiencing the same challenges as they are, and gives them an opportunity. Although we're a medical model, you've brought up social connections, and that's critical, Sarah, that we can maintain that as long as possible and promote success.
Yeah, no, I absolutely agree with that too. I think that just socialization is a great reason to put someone in your family member in a long-term care facility. Even if there's no dementia diagnosis, I think just that aspect, if you feel like they're isolated, that can be a really great option.
Social isolation, we know. I ran a home care agency. We know that can lead to feelings of sadness and depression. That connections are critical to the success of somebody living to their best ability, living independently with the right tools, the right interventions, as long as possible. And we celebrate those small successes that they have, because we're not looking at what's lost. We know that 2 parts of the brain are dying. We know that there's brain function impairment. But if we focus on that, we're missing who the person is. And that's the stigma that's associated. So when they see that other people are like them and not judging them and not criticizing them, they have a improved mood state.
Yeah.
And the least when we understand that, we can use less pharmaceutical interventions and more positive interventions. When we get to know who the resident is, provide the social connections, relieve those feelings of sadness and depression that when they're isolated in the home and they don't want to feel like a burden to their families.
Yeah, no, absolutely, 1,000%. Like, I agree with this. I've seen it. Working in long-term care facilities. And again, mentioning, like, I want to go back a little bit too. I want to backtrack just a tiny bit, because you did get me thinking about a few things that I did without even realizing that I was doing it in my CNA days. Anytime we would get a new resident, I would always look for pictures. And I would recommend this to any long-term care facility staff, I would always look for pictures in their room, because there would always be pictures of family members or pictures of them when they were younger. And you would always find some kind of picture of them either with a group of friends or holding a baby, or a picture of them, especially if they served. Oh, what branch of the service were you in?
Right.
Or again with the picture of them with their buddies. Hey, who are these guys?
Yeah, Sarah, you bring up a good point. We have a gentleman living in our community who is having trouble finding his apartment, but he still can live in our neighborhood, which we call a wing. We use positive terms such as neighborhoods instead of wing, which is more institutionalized, or unit. But he just has wayfinding difficulties, and we took the logo of his company and replicated that and put it on his door of his apartment. And the family brought a desk in, and he thinks that's where he works. After breakfast, he knows to go back to the apartment. The activity staff brings him calculating sheets because he was an accountant. So we give him numbers and things to empower him so he feels like he's going to the office. And that tool on the door serves multi-purposes. It helps him find his apartment so he doesn't feel like he's lost and confused and where should I go? The desk that the family brought in was duplicated from his office. The stapler, the calculator, his ledger sheets, everything is replicated so he actually feels like he's going to work. So we create success with that nonverbal language and using photos, logos from companies, little trinkets for the women. They love knickknacks and things like that. Anything to trigger them to keep communicating. And even if we put people living at the same level of cognition together and they retain social chit chat, we might not understand them. But the most important thing is that they're still talking, they're still using their words. And then we can decipher what their language is.
Absolutely. Yeah. And going back to that, when you're caring for somebody and you're not understanding them, what is the best way to handle that situation?
I always either one, I validate what they say. I first of all, I have to actively listen. I actively listen and I try to interpret the nonverbal communication or their nonsensical language. I might use an authentic apology. Authentic apologies strengthen relationships. Sarah, I'm sorry. I'm really sorry. I don't understand what you're saying. And then I might use whatever she's presenting with. If she's pointing to something or she's maybe saying some words that have meaning, home, I redirect. I might take them for a walk. Looking at the unmet needs. If they're yelling and screaming and they're jiggling doorknobs, it's a good clue that they're having wayfinding difficulties. They might need a bathroom. So I have to be very good at trying to focus on what is the unmet need? Why is her language getting heightened? Or she's trying to tell me a story that I just don't understand her words. I find that authentic apologies work very, very well. Redirect. They love to go to our little ice cream parlor. They can, we can go outside for a fresh walk and redirect the conversation away from that immediate, I have to tell you something, and it's challenging. Believe me, it's challenging. But when we train the staff to redirect, we could tag out. I have the staff tagging out sometimes. I might not understand what the person's saying, but I might bring in the primary care partner, which is our CNAs and our home health aides. We use that term care partner because everybody, including the family, participates in the care of the resident. And I'm a care partner as well, regardless of my credentials. That just gives me a better understanding and knowledge and more skilled. But we're all partnering for the success of the resident living with dementia. I might tag out with one of those people and ask to help me with the conversation. But generally, a redirection to an activity or food is great, or a walk outside. Fresh air is very invigorating. So we use those kind of tools to help us when we don't understand language.
Yeah. And I think that a lot of times, I think the two biggest behaviors or when I would see behaviors the most related to communication, it was almost always because someone needed a bathroom or or pain or was hungry. Those were kind of the three main things. And you could kind of rule out the bathroom by trying to get them to go to the bathroom, like, oh, we're right near the bathroom, do you want to go before we do whatever? That could rule that out. Oh, how about a sandwich? Or, oh, I got some crackers, hold on, I'll be right back.
We, yeah, we always use visual cues. So if I'm trying to rule out bathroom, I might open the bathroom door, point to the toilet to see if that's the unmet need, bring them to we have a bistro in every area. We have 6 different bistros where we can use snacks and treats to enhance the mood state and change the behavior. But when we talk about behavior, Sarah, it's always in a negative connotation. They're exhibiting behaviors. Even we see it on the TV with the Alzheimer's Association commercial where they're talking about behaviors. And I just spoke to one of our physicians about that and talked about how negative that is. And really all a behavior is, it's an action that causes a reaction, and it's their form of communication. So if I were to touch you and try to pull down your pants to assist in toileting, you might hit me or you might yell at me because, first of all, I'm touching you in a part of your body that you're not comfortable with because I'm a stranger to you. You might hit me because I didn't ask for permission and you didn't want to be touched. And I might be touching with my fingertips, which can be misunderstood as if they feel our 5 senses are exacerbated with dementia. So touch is critical. If I touch you with my fingertips and just rub your arm, you might feel like it's bee stinging you. So the staff is trained with how the 5 senses are affected, and your touch is critical to the outcome, which is a negative behavior. So when we look at unmet needs and we look at identifying what is the trigger to the behavior, we don't use that word behavior. We use communication. They're frustrated. They're communicating a need that we need as professionals to determine what that need is. And we can do it without the pharmaceutical interventions. Unless somebody's a threat to themselves or others, when we understand the language, which is critical to the talk today, when we understand their language and why they are doing certain things, we can lessen the amount of pharmaceutical interventions to control a positive outcome.
Yeah, absolutely. And I think that that's important to do any approach that lessens pharmaceutical interventions. And like you said, there is a time and a place where it's absolutely necessary.
Absolutely.
It does not mean eliminate it. There are times where, aggression can happen. And just as with people without dementia and adults without dementia that might be younger, that might have psychological things going on, that doesn't go away just because you get dementia too. You know what I mean? Like it doesn't go away. So if someone has a history of maybe they were abusive or violent, in their past and needed medication to keep themselves down, that doesn't go away just because they have a new diagnosis.
Look, time change. We just went through, spring ahead with the clocks. We here in New Jersey have experienced a week of rain and flooding. All these things factor into mood state. And we as staff members are all feeling low because we're sun deprived. We have to remember that these people are still who they were, and we have to get to the root of who they are and look at our own selves. Are we trying hard? Do we give up so easily? If you're not in the right frame of mind, it's very difficult to take care of somebody with dementia. And that's why caregiver burnout is so high, and why we run a support group for the caregivers. That's why staff gets time off, and that's why we have to take care of ourselves. All these things factor into the success. And as I said before, with the negative stigma associated with the disease, it's disheartening because I always say to families, they're still here. You can still hug them. You can still bring out who that person is. But if you're looking at it from my mother's not the same person. My mother doesn't recognize me. You're losing so much of those last quality moments in time that you can still create memories with her.
Yeah. I absolutely agree with that too. Also 100%. And I know that you've also put initiatives and work in place to improve quality of visits for family members and stuff.
Yes.
Would you like to talk about that more?
Sure. As I said, we're always trying to look to the positive, because there's so much negative associated with the disease, and families struggle so much. And we're seeing a lot more spouses placing their loved one in our type of community, and they're still living in their community where they raised their children, in the home that their wife or their husband just left. And that's very difficult after 50, 60 years of marriage to separate. So support groups are very critical. To have a meaningful visit, you have to remember who the person is. You have to focus on where they are at that stage of dementia. So as we talk, the family can do an activity in their apartment with their loved one. We can give them something to work on together to create a new memory. We can ask them to bring in the photo albums, go through the photos. Stop asking direct questions. Do you remember? If they're losing orientation, which is the hardest thing for families to cope with when mom or dad doesn't recognize I'm the daughter, that's very hard for the child. So we tell them to always introduce yourself when you go in. Hi, mom, it's Joan. I'm your daughter. And it helps to stir that memory. But when you show them pictures of when they were children, the person suffering with dementia remembers them in the past. So you need to be in their past. The hardest part of our job all day long is that we're in somebody else's world. We're in somebody's past, and we have to train the families. It's not about the present. You can talk about things in the present. You can show pictures of new babies being born, but they misidentify who the people are. So the conversation is very general. We have a new baby in the family. They don't remember the name of their grandchild that might have that baby and becomes a great grandchild. So we go through modules. Every month we have an education meeting, and then if they need me, they can call me and talk about what's struggling them. I just counseled a family last night about the woman keeps blaming her daughter for being in a facility, and she's having some periods of increased confusion and blaming the family. And you almost have to put your shield up and not take it personally. Just as the care partners that are working with a dementia resident here in the building, I have to say, you can't take things personally. You have to let it go, because they're not responsible for what they're saying, and that's why the authentic apologies come in. So I said to her, just say, Mom, I'm sorry that you're living here, but right now this is the best situation for you, and we can relook at this at a later date, but right now this is the best for you. And apologies always work. It de-escalates that stress or that feelings of being mad at directing their anger at their family. And so, communication again, going back to communication, going back to doing something that's engaging. Take your loved one out for a walk in the surrounding areas here, and photos, artwork on the walls in the building promote communication and positive relationships. But direct questions have to be avoided.
Yeah,
you can't, because they simply can't remember, and it's not their fault. And to stop with the blame game. I told you that yesterday. Families lose their patience very quickly because the conversations become very repetitive. So we ask that they too take a deep breath and remember that their loved one does have a brain disease, but remember them for who they are. Take the focus off the disease. We always seem to put the disease first, and we forget that these are human beings that need our support along the journey.
Absolutely. And again, the repetitive questions, and I can relate to that too, that can get annoying and frustrating as a family member, but it doesn't hurt you to just answer it politely, even if it's 800 times, it is.
Sarah, we're humans taking care of humans, and we
exactly
have our strong points and we have our weak points, and we have to be more cognizant of that and recognize if we're not on our A game. And that's where we tag out and say, you know what, I'm not good for this resident today. Can somebody help me? And that's okay. And maybe it's not a good day for a family member to visit because they've had a lot of stress at work, and that they bring that nonverbal communication, those nonverbal emotional feelings into the visit, which is not conducive to a positive visit. So they all factor in. So that's what the families are being educated on.
And that's a good point too about families sometimes not visiting when they're stressed out and when they're going through things. And that's something that a lot of times, a lot of family members don't realize. Like they just, it doesn't click for them that like, I need to, maybe I should just go home today and I can visit mom tomorrow. Um, I can't tell you how many times we've had family members walk in already upset, before they even walked into the door of the facility, and everything just escalates, and they're upset because whatever happened before they got there, and then they're upset at their mom because their mom didn't go to therapy that day, and then they're upset with the staff for not forcing her to go to therapy that day, and then it just becomes a whole,
Trickles down to the
it becomes
dementia.
it becomes a bigger thing than it needs to be, maybe. And sometimes upon investigation, mom complained of a migraine today and was really tired and wanted a nap. That's why she missed therapy. She's going to get therapy tomorrow instead. We were able to switch it, and sometimes in facilities where they have, in-house therapists, they have that flexibility. So, but it's certain things just get escalated sometimes when we're already upset. And
Right.
with dementia, it makes it worse. And then, the mom is upset about something else that happened way before now because she's reminded of it. And you have to de-escalate.
You have to out of the past, let that go, and let the remarks that your loved one is saying not hit your inner core and take it personally. But some families, it's a lot of uneducating them to what they know, to educating them on what will be successful and meaningful for them when they're coming to this facility. And they have to remember that they have to lower their expectations. Families sometimes are looking for the big bands. They're looking for a lot of stimulating activities, and our activity department has to be very fluid. If it's not working, they're told to shut down the activity and provide something quieter. And everything a dementia resident does living in our community is an activity, from brushing their teeth in the morning to washing their face and hands, or getting showered and letting people come and assist them, and getting to a dining room and eating. Those are all activities of daily living that the family doesn't consider an activity, but it takes a lot of remembering the sequence of the steps going into each one of those tasks, which is exhausting for the brain. We take it for granted, but for them, they have to process all those steps that it takes to do that task. And the staff is providing cueing and supervision along the way, and adjusting whether it's a demonstration cue or a verbal cue, depending on the stage of dementia. But I always tell families, you have to lower your expectations because your loved one has a brain disease and could not do that activity today. It was too much for them. And it's okay to say, come with me where it's quiet. So we always provide the critical thing also with activities is that recognizing that everything they do all day is an activity, but also recognizing that the brain needs time to de-stress and have some quiet time. We do, when we go home, we try to de-escalate at home and refresh our own brains to tackle this again tomorrow. So it's just as important for us to remember that as it is for the families.
Yeah, no, 1,000%. I agree with that. We don't always realize what is an activity or a task and how taxing it can be for someone whose brain is different than the neurotypical quote unquote normal brain. And that information can be applied, in any caregiving situation, I think, with any disease, not just dementia. Not just dementia diagnosis, but any type of even neurodivergence, even ADHD burnout, is different. And, there's certain tasks for people with ADHD that are just overwhelming that people without ADHD just can do no problem. So, you just never know.
When you're a caregiver, and it's critical that the staff recognizes it. And when I was out in the community teaching, looking for signs of caregiver burnout, because it's detrimental to the success of somebody living on this journey with dementia, because it's a long journey. And the caregivers, if they're family members, and especially we're seeing a lot of older caregivers in the homes. The spouse is in their late years, 80s and 90s, taking care of an 80 or 90-year at home. So their ability to cope is lessened because they're short-tempered, or so we're always looking for signs of that. But they're grieving the loss of a loved one, and regardless, like what you said, some of the other diseases that affect our brain, cancer with chemo brain. Whenever we're taking care of somebody, we're grieving the loss of who that person once was, and we want everything to go back to normal. But unfortunately, we're not miracle workers. We can't get into the brain and fix it. We can correct somebody's blood pressure. We can correct somebody's blood sugar. We can correct kidney failure by transplants now, and dialysis. I mean, we've made such strides, but with dementia, we're not making the strides that we wish. All the dementia care specialists and neurologists out there are hoping that we could speed that up and fix it, but we can't get into the brain. So if we don't change our approach, then we don't understand the disease. And yes, we're grieving the loss of a loved one, but that loved one is still here. And that's even harder than somebody who suffers loss through a sudden death or a journey with cancer. It's different because they're seeing the changes right before their eyes, and they want that person back to the way they were. But if you can come to some kind of an acceptance, and when we talk about Kubler-Ross and her stages of dementia, one of the stages that we get to is acceptance. When I can reach a family and get them to accept where their loved one is, it's half the battle with dementia care.
Yeah, no, absolutely. I completely agree with you. And one other thing I wanted to ask you and discuss with you, right now there's a huge movement of adults who are living with dementia, who are still currently living independently, and in their safe to do so, and they're becoming self advocates and advocates for future generations in dementia, where prior, when someone would get this diagnosis, it was the automatic nursing home, the whole, again, all the stigma, all the negativity.
Right.
I personally love seeing, because I've seen dementia progress in all different, again, 17 years as a nurse's aide, working in dementia units, working in assisted living facilities. I've seen it progress all different ways. Sometimes it plateaus in an early stage, and a person can function for a very long time and do most of the things that they could do before for a very long time. It still sucks, there's moments that still suck, of course. But as far as being able to self-advocate for people living with dementia, as a person living with dementia, that is huge. That is something that I'd like to see more of. And I'd just like your opinions on that.
I think it's wonderful. I've been privy to being in conferences where people with dementia speak. We see people with vascular dementia, just as you said, can plateau for a long time. An illness such as a urinary tract infection, sepsis, there's a drop in cognition, and then they plateau and can live like that for a long time. I think people living with a disease, whether it's dementia, whether it's Parkinson's, whether it's cancer, when they can speak to us from their heart, we can learn what's important to them, what they like about us trying to help them, the professionals and the frontline staff helping them, and what they don't like, and we can make adjustments. There's nothing better than hearing from the person experiencing it as the trainee for us, so that we can make improvements and improve quality of care and quality of life. I think it's that simple. We want the best for these people, and who better to teach us than somebody living with dementia? And I've learned a lot from people that have this brain disease, and I think it helps be more sensitive, more passionate, more caring when we see what their struggles are and how we as professionals can advocate for them. We can make those environmental changes. We can educate the community on our words and our nonverbal communication. So I strongly advocate for people that can still have that ability to help us learn more about who they are now with a brain disease. It's a win-win situation.
Yeah, absolutely. I really just love everything that you're saying. And I know I know that your work can be very, and I hate to say it because it does go with negative language, but it can be taxing. It's all jobs are hard, but working with people with dementia day in and day out can be, again, like you mentioned, caregiver burnout is huge. So what do you do for yourself for self-care?
So that's a great question. And yes, there are times where we as specialists, right, Sarah, we use negative words, but we try to correct it and go to the positive. And I don't want to be like, the person that's looking at, there are hard times and there are difficult challenges that we face as professionals. I always say to my own family and my friends and colleagues that the hardest part of my job is not the physical care. When I worked in the hospital, it was more physical. Here, it's more mental stress. I'm in somebody else's world all day long, and we call it therapeutic fibbing when we're actually lying to meet somebody at their journey. If I told somebody who's screaming for their mother that their mother was dead 20 years ago, I'm going to get a negative behavior back. So we use therapeutic fibbing. And I have to remember when I leave the building every day, every night that I leave here, I just stop, take a deep breath and say, I'm in the real world now and I can't fib to anybody. There's no more lying. But for my own self-care, I do a lot of traveling. I'm a widow. I was a young widow, and my husband made sure that I was financially secure, that I could travel. I met a nice retiree from the industry, and she and I have been traveling, and I find that that helps me. I do a lot of reading, and I'm a very spiritual person. I really have a strong belief in my faith, and I really get a lot of strength when I'm meditating or praying. Church, sometimes I'll just sit in the church and just be surrounded by the calmness and the peacefulness of the atmosphere. But self-help is important, of course, getting your nails done, and massages also help, but you have to remove yourself from the situation, otherwise you would suffer burnout. And unfortunately, sometimes it follows me when I'm traveling. My friend has a habit of telling people that I'm a dementia nurse, and there's always somebody on my trips that knows somebody with dementia. So we never truly get away from it, but de-escalating from the dementia world is critical for my success in helping people on the journey.
I love that. I think that that's great. Again, I think that faith and spirituality, wherever you lean with that, whatever floats your boat with that. I think that that's super important for caregivers to lean into. I think that there can be so much benefit and something that you can do in any moment, and it's easily accessible. And I love traveling and getting out, seeing different places. And I can agree with you, actually. I have a little bit of a story, if you don't mind me sharing, about we were camping and I was drinking. We were in our early 20s, we're camping, I'm drinking, and an elderly person fell. I had been drinking pretty much all day because we were camping. And I don't even think I had met my husband yet. I think this was before I even met my husband. And my boyfriend at the time was like, "Oh, she's a nurse's aide. She can help." I'm like, "No, no, 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 no." Like, first of all, I'm on vacation. Second
Yes.
of all, I've been drinking all day. I am not helping anybody.
Yeah.
I'm like, this is a lawsuit waiting to happen. I'm like, I'm sorry. I'm like, I can help you get your family. I'm like, did you hit your head? I'm like, I've been drinking all day. I don't think it's safe for me to help pick you up right now. But
Yeah,
I wanted to injure him in that moment.
I empathize with that story because, not only am I a dementia nurse, but I've been a hospital nurse for 20 years. So, I am handling those things. I always seem to be arriving at the scene that there was an accident. The police haven't even arrived yet. I don't think I think it's an identifiable characteristic of mine. I think that my character was drawn to my profession. I think that the way my inborn characteristics led me to the profession that I'm in. And I don't think I ever fully get away from it. But I've learned now that I'm getting older in my career that self-help is critical to being available for those that really lean on us. And, when we talk about nurses' aides, sometimes we talk negative about them, but they're the nurses' eyes, ears, shoulders, hands. We lean on our frontline workers so much, and we don't give them the recognition they deserve, because they're really at the first and foremost of the behaviors and the daily operation of what's going on through somebody's life. So, I always try to also be very aware that I need to be putting them first and foremost, recognizing their needs, stepping in and pitching in. Go on another break today. I saw how hard you're working. I'll help feed this resident, or I know you're struggling. Why don't you go out and get some fresh air? I'll stay with this resident. So, we always pitch in and help where we're needed. And I think that's just our personalities. But it's important that you really have to get away from it.
Yeah, absolutely. Take days off.
Yes.
And your day off is your day off. You're entitled to it.
Yes. There has to be a balance. Right?
Exactly.
Life, we have to have balance.
Exactly. I love that. Thank you so much again, Joan. And my final question, where can my audience find you for more information?
So my contact information is Joan Dipaola. I am a registered nurse, a dementia care specialist. I work at Harmony Village, Care One Paramus. Care One has a website and a phone number, but I can give you my contact number here. It's 551-276-7203. That's a direct to my office, and I'd be more than happy to answer any questions. On the website, you can see my email address as well. It's my first initial last name at care-one.com. The spelling of my name is Dipaola. And so it's my first initial, my last name at care-one.com.
Awesome. Thank you so much. And I will have all that information linked in the show notes for my audience. If you guys have any questions or anything like that, reach out to Joan. Joan, thank you again so much for being here.
So much. And I look forward to future conversations with you as well. Thank you for what you're doing for the community as well.
Thank you. And I just, again, everyone, it was great having Joan on to talk about this. I know you guys can't see me, but my whole face, I'm like smiling big because dementia care and, this is just where my heart has always been and still is, even though my life has drawn me to other things. But with that, I want to wrap up this week's episode of Caregiver Chronicles. For more information, all of Joan's links will be in our show notes. You can find them on our website. You can also stelmachbrownmedia.com. You can also find more information through our Facebook page and our social media pages. If you liked this episode, you liked what Joan had to say, you're interested for more, please share it out. If you know somebody who could benefit from this information, please share it with them. If you want to support this podcast, you can do that through our website, again, Stelmach Brown Media. But really, the best way to support us is to share our show with everybody who needs this information. With that, thank you so much for listening, and we'll see you next week.